The ideas expressed in City Club forums are those of the speakers and not of the City Club of Cleveland, IdeaStream Public Media, or their sponsors. Production and distribution of City Club forums on IdeaStream Public Media are made possible by PNC and the United Black Fund of Greater Cleveland, Incorporated.
It's Thursday, July 10th, and I'm Michelle Nida, Executive Director of Philanthropy at Cleveland Clinic and proud member of the City Club Board of Directors. I'm pleased to introduce today's forum in partnership with WellLink Health Alliance and part of the City Club's Health Innovation Series. Artificial intelligence, or AI in healthcare, is experiencing a surge in new technologies and applications. More specifically, Generative AI is a form of artificial intelligence that's trained to find patterns in data and then generate new content. AI can enhance patient care, optimize clinical workflows, and drive innovation while maintaining transparency and ethical integrity. But no matter how innovative and revolutionary the application, the future of AI in healthcare and its successful adoption is driven by patient trust. Today, we are joined by leadership from local health systems as well as experts in AI technology. They will discuss real-world applications and challenges in building confidence in AI's role in healthcare. How can we shape a future where technology and human expertise work seamlessly together? Here with us to answer this and more is Dr. David Kelber, Chief Health Informatics Officer and Vice President of Health Informatics and Patient Engagement Technologies at the MetroHealth system. Karen Commander, President and Founder of Health Literacy 360, LLC, and the U.S. Health Literacy Association. Brian Lane, President and CEO at WellLink Health Alliance. And Jennifer Owens, Senior AI Program Administrator at Cleveland Clinic and co-chair of the AI Center of Excellence. Moderating the conversation today is John Paganini, President of Paguar Informatics, Inc., and co-chair of the AI Center of Excellence. If you'd like to text a question for our speakers, please text it to 330-541-5794, and City Club staff will try to work it into the program. Now, members and friends of the City Club of Cleveland, please join me in welcoming our guest today.
Hello, everybody, and good afternoon. Welcome. I'm honored to be moderating this panel today about this very important topic of trust and bringing AI into healthcare. It's pretty exciting times that we're in, and we're going to have a very engaging conversation from a human perspective on where we're at and where we're going and how we're addressing these areas. To many of us, AI can be a mysterious term. It's a buzzword. And if we went around the room, probably every one of us would have a variation on what AI means and the definition of that. So I'm going to ground us, at least for the next hour, on a definition of AI. So artificial intelligence is an ability of a machine to perform a task that requires human intelligence. So let me say that again and let that sink in. It's the ability of a machine to perform a task that typically requires human intelligence. So what does that mean? Well, recognizing speech, as an example, or interpreting or trying to interpret a pattern, or learning from knowledge, or even making a decision. These are things that human intelligence traditionally has done, and now computers and machines are doing that. And AI has been around since 1956, when the term was first coined by some visionary leaders from Dartmouth who saw that a computer could possibly simulate human intelligence. And at the same time, I'm a science fiction kind of person, Robbie the robot from the movie Forbidden Planet came into being, and all of a sudden we saw on the silver screen something that could think, it could talk and reason and have emotions. And so maybe our fascination with that artificial intelligence and maybe uneasiness, like we saw later on in 1969 with the movie Space Odyssey and HAL, those fears started to materialize. So let's fast forward a little bit. 1960s, GM put robots in assembly lines. Then we had decision support system, expert systems, and then they came out with neural networks, which tried to simulate how the brain makes connections in the neurons, and then machine learning. And machine learning is, an example of that would be to take thousands of images of cats, feed it into the computer, and eventually the computer says, I got it. I know what a cat image looks like. It may not, and back then, know what a cat was, although that has changed. So that is the beginning. It wouldn't know what a tree or a dog was, but I got it. I know what a cat is. So my own career in healthcare started back in the 2000s when we were taking mammography images and tried to detect cancer in those images. And we did it with other diseases. We even tried working on pathology, digital images of tuberculosis slides to determine tuberculosis existence in South Africa. So that technology has been around for decades at this point. So we'll fast forward and we'll think about IBM when Gary Kasparov, of course, lost to IBM Deep Blue. And then, of course, moving forward, IBM beat humans at Jeopardy in 2011. And I had the opportunity to work on the IBM Watson project at the Cleveland Clinic, where we actually extracted data from Epic, de-identified it to protect the patient information, and securely sent it to IBM Watson. And then IBM Watson would come back and say, here's a nice dashboard, and you know, I'm 80% confident that this is the diagnosis, right? But if you ask it this question and tell me more, I can get you to 90%, which was very much eye-opening and groundbreaking to think that a computer knows what it doesn't know, and it can get smarter if you help it get there. So now fast forward, here we are, we're talking to Alexa, we're having Netflix tell us what movies we want to watch, Amazon is telling it what we should purchase, our thermostat's telling us what temperature we be set at. So here we are today in this modern world where AI is among us. But something has changed since then. Things have changed. Those models, those generative AI models of reasoning are getting better and better. It's actually showing us how it's thinking and why it's thinking about that. The predictive algorithms are getting better, the large language models. We are at a major point in history as humans with this AI technology. So we've got to make sure that in AI in healthcare, that we're managing this from a responsible perspective. And as it was said earlier, we need to be able to trust the output that is coming from this AI, that is being generated. We need to make sure that the humans trust it, the humans actually receiving the output, that is both patients and clinicians. And so we can progress, but we have to progress with integrity as we're moving forward. So that brings us to really the first question to today's panel, and that is, with all of this new technology, this shift in how we're thinking about healthcare, what are some of the risks and what are some of the opportunities that we need to be concerned about. And I'm going to look to Dr. David Kalber to start us off from a clinician perspective, and then maybe Karen from a patient perspective, and then of course the rest of the panel will chime in. So Dr. Kalber, kick us off.
Thank you very much. Very excited to be here. As a physician, I'm super excited about the potential of AI. And it was sort of alluded to, the way I really frame it is this is the third generation of AI or artificial intelligence. So at Metro, we installed the Epic electronic health record all the way back in 1999, and we were already using simple rules-based AI at that time. So what might be an example of that? So if anybody in the room has an allergy to a medication, and I was trying to prescribe that medication, the system would tell me, hey, don't prescribe this medication to this patient because they have an allergy. I mean, that's very simplistic, rules-based AI. Then when we advance, sort of the next generation of AI would be predictive AI. So for example, some of the things we're doing at MetroHealth is, I'm sure none of you have ever no-showed, none of you have ever not shown for an appointment or no-showed, right? I mean, this happens a lot as a doctor. We have a predictive model that predicts if a patient is likely to no-show for their appointment, and then we can try to adjust accordingly. We also have another predictive model that looks at when someone is in our emergency department, what is their risk of possibly having sepsis? Because sepsis is a very important medical condition. If we can intervene a little bit earlier, we can have an improvement in the outcome for that patient, both in terms of mortality and in terms of length of stay. So these have been around for a while. What's happening now in the generative AI space is really generative AI talks about new knowledge being generated, as was mentioned before. I think, to me, this is the most exciting part of AI, although it's still early in its infancy. One of the generative AI tools that I had a chance to try for the first time, actually this past Monday when I was in clinic, is something called ambient listening. So just to describe that a little bit, how many of you have been to your provider recently, and what's the provider doing? They're sitting, typing in front of a keyboard, right? They're not looking at you. Hopefully they're looking at you some, but they're still spending a lot of time looking at the computer because they're entering a lot of the information about the conversation. Well, generative AI has the opportunity to transform that encounter. I don't know if anybody of you have experienced that with your provider, because all of the three major healthcare systems now are looking at ambient listening, where I would take out my phone on Monday and say, is it okay, again, we want the patient permission for this, but is it okay if my phone listens to our conversation? It's not just going to transcribe the conversation, but what it's going to do, it's taking everything that we're saying as part of that discussion and putting it both into a patient-friendly format, so the patient can review everything that was talked about, as well as sort of a traditional doctor's note, so to speak. And it means that I don't have to spend a lot of my time typing what's being said, but can spend a lot more of my time in that patient-provider interaction. So it's things like that that I think really have the opportunity to really transform the healthcare system today. And there's lots more examples that I know we'll talk about in the panel.
Good. And Karen?
Yeah,
maybe the
thank
patient
you.
perspective.
Really thrilled to be here. Hello, everyone. So I want to kind of follow up on what you said about patient choice. That's kind of where I'm going to go here. As AI becomes more visible, it's becoming more and more visible today. In the past, it was more behind the scenes. But as it becomes more visible, I think one of the first things we need to talk about is patient agency. Right? Patients have the right to know when and how AI is being used in their care. And that transparency and the choice helps to build trust. But trust isn't built just through disclosure. Right? It's built through patient understanding. And that's where health literacy comes in. Now, I know that's a term that's not widely understood, so I'm going to take just a moment to define it here. The Department of Health and Human Services, in their Goals for Healthy People 2030, redefined health literacy into two parts. First, there's personal health literacy, which is an individual's ability to find or access, understand, and then use health information to make decisions for themselves or others. Second part is organizational health literacy, and this is really important. This is about how well organizations and health professionals support that individual's ability through clear communication, access, and thoughtful design. Now we add a third layer, AI health literacy, which is about the ability of individuals, communities, and organizations to understand and then effectively engage with AI technology. So I think this is all really important right now, right? Because I think, who would agree our healthcare system is already really complex?
Oh, yeah.
Really complex, right? In reality, 9 out of 10 adults in the US have difficulty understanding health information. And I'd like to share, I lived that firsthand. For over 2 decades, I navigated the maze alongside 3 of my siblings, all diagnosed with a rare, debilitating disease when they reached their 30s. And despite being a registered nurse and an educator, I found myself often overwhelmed and frustrated with the confusing language, miscommunication, and really a system that just didn't really reflect what patients need. Our family motto actually became, "We do hard." So I think the risk is that if AI is not designed and implemented with the patient voice in mind, we may be leaving more people behind. But I also see real opportunity. As Dr. Kabler mentioned, it frees up providers to actually spend more time with their patients. It can also catch problems earlier, right? It also can reduce barriers to access, especially for those folks living in rural areas or primary care deserts. So I really see an opportunity here. But again, if AI is not designed with the patient in mind, we, again, may be leaving people behind.
I love the patient focus of that. And I also love, David, that you holding up your phone said very openly, "May I?" and "Can I?" From a patient perspective. And I think that the patient is sometimes overlooked from the perspective of utilizing AI within healthcare, because the patient can actually utilize AI to actually figure out their own questions to ask in advance of actually meeting with the practitioner. And then AI has been in our marketplace for a number of years. We just don't really call it AI, but wayfinding, for example, is a form of AI that we use, every single person in here uses each and every single day, some to even get to this building today. And so, I want you to know that AI is an extension of your life. It's an extension of your well-being, and it's also a means for us to get to the verb, which means taking care of those patients better, but the patients also have a responsibility of utilizing it as well. That's what I like to say.
Yeah, I think 2 things that really stick out to me from our previous comments. One is Dr. Kalber's point about really needing to gain the patient's consent in order to use this tool. And then second is Karen's comment about the opportunity to educate our healthcare providers as well as our patients. If I'm in a meeting, or not a meeting, if I'm in an appointment with Dr. Kalber and he says, "Hey, may I use this?" And I say, "Well, Dr. Kalber, tell me about how it works. Tell me about what it's doing." He's going to be able to give me a bite-sized bit of education that's going to help both of us understand. So we really do have kind of a dual burden of education, not only for patients, but also for our caregivers.
True.
Right. Yeah, not just patient agency, but patient empowerment
Right.
at the same time. Okay, so we've heard that the AI is making healthcare faster, better, safer, and we have to think about the trust side of that, because at its core, healthcare needs to be embedded and deeply rooted in trust as well as the human aspect of this. And so the next question to the panel is going to talk about how can AI make the whole experience more personal? How can AI really push us further when it comes to the personal aspect and the human side of the engagement between clinician and patient? So I'll open up to that to the panel.
Can I hop in? Because at Cleveland Clinic, we've got we're in phase 3 of a implementation plan for an ambient scribe. And so we actually do have some pretty solid data and some anecdotal evidence as well of how this tool is changing our provider and patient relationships. I brought my notes because I wanted to accurately reflect this. We had a patient reach out to the ombudsman with a report about an encounter in which their provider had used an AI scribe. And if you work in healthcare, you know how rarely patients reach out to the ombudsman with a positive review. But this one was so noteworthy that I wanted to share it verbatim. And this says, Dr. X took time and patience with me. With the new recording system, she could listen to my concerns and speak to me directly without having to type everything into the computer. Very reassuring and important in patient-doctor relations. And I think this is really important to call out because when you're evaluating as a healthcare system an ambient scribe, all of their marketing tools come in with saying, this is gonna reduce your burnout. This is gonna help your patients feel more comfortable. It's gonna improve the amount of time that your caregivers are gonna be able to spend in face-to-face interactions with the patients, not distracted by trying to do documentation and listen to the patient at the same time. And we find that our providers actually do report this. I just wanted to quote again, they say that today is the first day I've enjoyed my job in 10 years, which is always really exciting to hear. We say, I love this product and it is already very useful to me. This was from, I believe, day 2 or 3 with the product in their hands, which was amazing. And then my favorite one is, this makes tomorrow much brighter. We hear a lot about the stress that documentation puts on our healthcare providers, not only to create the documentation, but also to find and collate and create a narrative out of documentation that's already there. And so to see these tools really living up to their hype and living up to their promise of being able to change the relationship of our providers with our documentation is huge. It's very encouraging.
I'll jump in if I may. But it might turn into a little bit of around Cleveland Clinic.
Sure.
Which I'm just going to surprise you with, if that's okay.
Love surprises.
All right. So WellLink, our team here, and thank you all for being here, as well as our board members, challenged us to actually go out into the nation and offer a grant. We did, and actually Cleveland Clinic came back with a request to work with us along with our strategic partner, AWS, and the clinic's request was, can we use the platform as well as the AI analytics tools to look at COPD and asthmatic patients? We put 186,000 patient records in, and it was a study that was supposed to take literally for 3 years with 5 different researchers, so pretty big exorbitant cost. In 6 months, we actually had the study done. Note that, mic drop. Okay, you can laugh. That's good. And out of it, we had an aha moment, right? And for the researchers, as well as the administrators, the data clearly demonstrated the link between social vulnerability indices, right? SVIs, SDOH for those that are in the know, around COPD as well as asthma exacerbation rates, especially among individuals lacking health insurance, lacking housing, lacking jobs, lacking food, and living in poverty. Okay? Right? Three main neighborhoods as well within our area. So the platform enabled us to have accurate code-free production of an effective clinical management tool. It saved the researchers a tremendous amount of time. And most importantly, right, it's enabling us to actually help save lives. And this is what I want you to understand. The shortening of the time, the ability to get to the actual verb, the outcome, enables us to then react properly and dial directly into those who are in specific need. Does that make sense?
Yeah, good stuff, Brian. And to add to that, if we think about how long we have been electronic, we've only, as David mentioned, we've had Epic in place in all the major hospitals recently, which is great for interoperability, by the way. But we've only had 20 to 25 years of data in electronic format, which is why we can now start examining and exploring and analyzing all of that data better than we ever could before. Any other comments on AI and how it's helping making patients' lives better?
I think I just want to add, from the patient perspective again, is that AI can help translate to a patient's own learning style and their language. It can translate, excuse me, medical jargon into plain language. So those are a couple really important things. And as was already mentioned, it can suggest questions to ask the provider before the visit. So I do see a lot of ways that AI can make it simpler and more personal for the patient.
Okay, moving on. AI, we've established, cannot move forward in healthcare without having trust embedded. It can't work in theory. In healthcare, it must be safe, it must be ethical, it must be equitable for every patient. So in a clinical setting, we have to think about something called healthy AI skepticism, right? This is good to be a little bit skeptical. We can ask the questions that we need to. It's our responsibility. It's not resistant to the technology. It's just making sure that we're not blindly adopting it, and it is being implemented thoughtfully. So how can we earn that trust? How do we manage the risk? And what are the things that we're doing to ensure, and I'm going to talk about governance, so Jennifer, maybe you can help us out there, but what does skepticism look like in a hospital setting with AI? And how do we build that into our implementation process?
Boy, I could talk for a long time on this, so give me a wave when you want me to be done.
Okay.
So in my day job at Cleveland Clinic, I end up flipping back and forth between being an AI evangelist and an AI governance person, which means I am often saying, yes, we should do this right away, and also, no, we should wait and do more research on this, kind of at the same time. The things that I've learned is that having a structured governance process can really help frame your innovation in a way that speeds your route to full implementation. AI is scary to many people, and to be able to share the ethical principles that underlay a governance framework and the criteria on which any AI tool is evaluated before it hits your production environment goes a long way towards calming the fears. I also like to remind myself frequently, when I sometimes get frustrated, is that behind every skeptical question is a real governance question. So, is this any good? That's something we should be answering as part of our governance process. Does this model do what we think it does? Does it do what it thinks it's doing? Does it have the impact on our patients or our providers that we thought it was going to? How are people thinking and feeling about it? Does it feel like it's maybe privileging certain types of patients who might have different kinds of data, or maybe more, like patients who may have a different profile than others? Those questions are all informing a governance process. The other thing that I really want to say is that having really clear standards. Okay, so your model must be validated. It must be validated on the data in our environment. It's not enough to say that it works really well at Stanford or at Mayo. It must work well for Cleveland Clinic in our environment for our patients if it's going to be beneficial for our patients. And then secondly, and I'm going to look at Karen here for a second, because a governance process needs to incorporate perspectives from multiple subject matter experts. That should include cybersecurity. It should include your law and your compliance divisions. It should include your data and your data science and your analytics people, but it should also include a patient advocate. Because a lot of our projects that we see come through start with the idea where somebody gets very excited about our 25 years of Epic data and says we could do something really cool. But to have somebody, a clinician, a patient, an administrator say, okay, let's talk about how this is going to benefit our providers, our patients, our organization, to have that hook into reality and to be governing, not only does the model do what it says it's going to, but how are we using it? Just to go back to Dr. Kalber's excellent example about patient no-shows, right? You can create a model that will predict a patient's probability of no-showing, but what you do with that information is just as important and should also be governed by your AI governance. Do you double book them? Do you call them and offer them transportation? Do you do both and more? The actions that you're taking with the output of your artificial intelligence are just as important, and they should fall under your governance model as well.
That's excellent.
I guess I would just add, I mean, at Metro, we view governance as sort of like that tip of the spear to try to figure out what we should be doing. Then, and I think sometimes this frustrates our end users, we really find it critical to do a lot of testing before we put AI sort of out into the wild, so to speak, either with patients or providers, because we recognize that because these AI tools are looking at our data, they may perform differently than the same model, at the Cleveland Clinic or somewhere else. And then the other point I would bring in is this concept that, I say, it's not that AI is going to replace people or replace physicians, but physicians with AI are going to replace physicians without AI. And part of what this, sort of the way I frame this too, is it means that at least at Metro, we always think about there's still a provider in the loop. So for example, with this ambient listening I was talking about, it's not that that note just goes blindly into the chart, because maybe there's something wrong with the note. Maybe there's a hallucination from the AI. People have heard about that. So it's still that the provider needs to look and make sure that that note accurately represents what was happening. Or same thing with like the sepsis alert. It's going to a doctor or someone else on the healthcare team, and they still have to make that final decision of, do we believe the AI? Are we going to do something different with the AI? So there's always this idea for clinical facing generative AI or other types of AI, that there still is a human, a physician, a licensed provider that's actually making the decision. It's just providing more information to them that hopefully they can make a better decision.
Yeah, well said. There's always a human in the loop is where we're at. And we as humans are responsible for the decisions that we make along those lines. Good stuff. So one of the things, Jennifer, you mentioned is when we build these systems, and bias has come up, even though the word wasn't said, we have to consider that these systems need to be designed from the very beginning, in the design stages, with this bias, this trust, this transparency. And when we say transparency, what we mean by that is it's not a black box. We understand why the AI is generating this output and helping us make better clinical decisions. So good content, a lot of good conversation here. And we're going to go right into kind of the final questions, if you will. And so we've talked about the patients a lot, and we want to stay on that note, and why communication is critical, and why the patients deserve to know why the AI is being used, how it's being used, why they can feel confident, so that we establish trust between the clinicians, trusting the AI, and also the patient who is the recipient of this information. So it's not just about disclosure, as was mentioned earlier, it's about patient agency and empowerment. So what are some of the ways that we can openly and effectively communicate when AI is part of the care? And Dr. Kalber, you brought something up earlier, but how do we make sure that it builds trust and works in a way for people of different levels of health and AI literacy, if you will, in the hospital setting?
I'll take that.
No, go ahead.
Okay, I'll take that one. This is really an important question, because when we talk about transparency, like you mentioned, we're really talking about empowerment. So it's not enough to say AI was used, right? We need to say how it was used, why it was used, and how does it play a part in the patient's care in ways that people can actually understand. Now, that's not always easy, because people have different levels of health and digital literacy. Some people may be curious and are eager to learn more, while others feel overwhelmed or maybe even fearful. So that's why communication needs to be inclusive by design. And one way to accomplish that is to use evidence-based health literacy principles, starting with universal precautions for communication. And what that means is that we assume that anyone has difficulty understanding complex health information. So we use plain language with everyone. We avoid the jargon. We stick to everyday language, right? And we explain clearly what AI's role is. So we might say something like, well, this tool helped us catch this problem early, but your doctor is still the one making the final decision. So then we follow up with teach back, right? So here we ask the patient to explain back in their own words what it is that they heard or understood, not as a quiz, right, but to make sure that we're clear. But it's important when we ask the question that we show that we're the ones taking responsibility. So we may say something like, I want to make sure I explain this clearly, so can you tell me ... So that's how we build AI literacy alongside health literacy. We're not just explaining a technology, we're showing how people are still in the center of their own healthcare, even in an AI-enabled environment. Because again, at the end of the day, people trust what they understand. And if we want AI to be trusted, accepted, and used equitably, it starts with communication that meets people where they are and brings them in to be partners in their own care.
That's great. We have time for one final comment.
Can I throw
about
one
the
in
subject? Yeah, please,
around this?
please,
I love the plain language component. I love the empowerment around the patient. I would just include the families within that mix,
Absolutely.
FYI, because they're care providers as well. I also believe that we cannot ignore that patients, lack internet access, and so we need to make sure that they have the digital tools, the access points to utilize these tools as well, right? Because if we don't do that, then we're leaving people behind. We're already facing healthcare barriers. I would also like to just throw in, we need to be very conscious of the social factors like income, education, housing, shaping, how people are utilizing the information. The risk is if individuals don't have the tools, well, then they're being left behind again. And so let's not do that.
That's great.
Okay.
Final comment. And you mentioned all those, you mentioned SDOH before, and that means social determinant of health, which you just alluded to. So I'd like to thank the panel. We're going to be moving on to the Q&A, so awesome job on the panel. So we're about to begin the audience Q&A for our live stream audience. I'm John Paganini, president of Pagwar Informatics and co-chair of the Northern Ohio HIMSS AI Center of Excellence and today's moderator. We have been discussing and will continue to discuss the future of AI in healthcare. Joining us on this stage is Dr. David Kalber, Chief Health Informatics Officer and Vice President of Health Informatics and Patient Engagement Technologies at MetroHealth. We also have Karen Commodore, President and Founder of Health Literacy 360 and President of the U.S. Health Literacy Association. Then Brian Lane, President and CEO of WellLink Health Alliance. And finally, Jennifer Owens, Senior AI Program Administrator at the Cleveland Clinic and fellow co-chair of the AI Center of Excellence. So we welcome questions from everyone, City Club members, guests, and those of us joining us via live stream at cityclub.org.
Well, thank you all very much. I'm Jeff Brown with Cleveland Clinic Concierge Medicine. Did my training at Metro. Thank you, Metro. Spent 15 years in IT first. And so the Achilles heel of any system has always been garbage in, garbage out. So how do we ensure that this massive amount of data going in is clean? And then also the data that comes out, how do we ensure that it is being appropriately worked on for populations? So it's not a one-size-fits-all.
I can start that off.
Please.
I'll take one aspect of that. And we mentioned it a little bit earlier about training these systems very early on in the process to address things like bias and safety and reliability. But a new process that's emerging is that data could soon be outdated. And therefore, we need to either recalibrate the data or retrain it totally, that model, to address some of those population areas that you mentioned. So, any other comments?
Just one. I'd like to make a comment about using tools that are patented already, that have data that has been evidence-based. And I'm thinking particularly of different programs that translate patient material into plain language. So there are tools out there that use already evidence-based readability tools, but also take into account culture and language, which is really important.
Coming from the GPO side, which is a group purchasing organization, we run one of the oldest group purchasing organizations in the country. We see a lot of vendors. And so I would like to add a couple of things just regarding vendor selection as well as how to deal with the overall vendors. But it's been said, regarding full transparency, no black boxes. But you also need to know proof of performance, the validation. You've got to have your expectations put into place to actually get the right solutions. You've got to hold the vendors for accountability regarding their overall outcomes. They have to be ironclad regarding their data and their privacy and their security. They have to be adherent and knowledgeable around HIPAA from a compliance perspective if they're dealing with patient data. They've got to be seamless, as well as understand integration into your other data sets. This is where roles such as David's here become very interesting because they're having to actually look at and help govern. And Jenny is the governance administrator for Cleveland Clinic. These positions are new, and evolving and taking on a tremendous amount of new responsibility.
And there's another new position too. You might machine learning ops engineer, and that person is responsible for making sure the data is maintained and always accurate and watches for deviations in those models.
And hallucinations.
John, can I just lampshade what you said? Because I would be doing my friends in data and analytics an enormous disservice if I didn't call out, you've got your finger right on the problem, right? That the data is sometimes unclean, it is sometimes multiple versions all jumbled up together, and the role of data engineering in making sure that the data that you're putting into your model training is reliable cannot be overstated. That being said, that also needs to be married with post-deployment governance and monitoring and auditing so that as your data continues to evolve and grow and change, your model performance doesn't drift and you have a clear escalation pattern. You know who to escalate to and when to ring the bell and say this model actually needs to be retrained. It's different enough from when we built it.
There's a deviance, yeah.
I would add really quick, I think, and you alluded to this earlier, I think part of the hope, because it's really hard to clean up 25 years worth of data, is that some of these systems are starting to be sort of self-correcting and self-identifying, right? So it's that idea with the IBM Watson Health of saying, hey, I think there might be some problems with the analysis that I presented. So I think to me, that's sort of a new tool that's coming online with generative AI, this idea that the generative AI can help identify and maybe even correct or at least point out data issues.
I think instead of what you're saying, Dr. Kalber, is instead of physician heal thyself, data heal thyself.
Yeah.
Okay. Are we good on that question?
Here?
Yeah? Okay. Good. Okay, next question.
Good afternoon. My name is Mike Kenny from Cuyahoga Community College, and thank you to the panel, Karen especially, for bringing out the voice of the patient. 30 years ago, I had the pleasure of judging a science competition of middle school students. This group of rural North Carolina students, 12 to 14-year-olds, proposed a universal medical record system. We are very fortunate here in Cleveland that we almost have that. How would such a system benefit the use of AI in healthcare?
Immensely. Truly, when we talk about just navigating through the system, and when patients have to go from one place to another and answer the same questions over and over and over again. How many of you had to do that?
Everybody.
Yeah, everybody here, right? So I think that having the full system where all of the data can be in one place will really ease a burden, not only on the providers, but I'll tell you, on the patients and their families as well.
If I could just give my personal opinion on the fact that all the major hospitals are now using one system, the same system, that interoperability, that is that ability for one hospital's records to talk to another hospital to talk to another, has dramatically improved over time. And I've been involved in interoperability for many, many years, and it's been a challenge, but that has made it easier. It's also made it easier for people to move around in Northern Ohio as well. So that was kind of a good benefit.
It's a great benefit.
Yeah.
And we should be thankful for our hospital health systems for making that a large-scale investment.
Okay. So the answer is that'd be great. We're approaching that. It may never exist, that one major record. We're still working on a medical record number for all people, and that's been elusive as well.
Joe Smotsny, Centric Consulting. Thank you, panel. Did a great job, very informative. Love hearing all the examples, too, from the local hospitals and systems. My question has to do with educating doctors, in particular newer doctors, and in what ways might this all change the way we educate those doctors? And I'm looking at the context from my company does a lot of IT stuff. I know AI really well. I don't know healthcare. And so I'm just a normal patient. And when I go to the doctor, especially if it's, I'm the typical OG, the old guy, who's got the doctor who's very young, and I'm asking questions, and I'm wondering, like, how much of their expertise are they using versus a tool? And then I pull out my phone, and I ask ChatGPT the same question I asked the doc, and I get two different answers. So this is, doctors don't hate me for this, because I don't do the WebMD thing and like say my doctor's wrong, but how might that actually change the way we educate doctors so they're aware that that trust factor might not be there, especially with the OGs of the world?
I mean, I'm very sensitive to that question in a positive way.
Hey, you live it.
I think there's two things we need to think about. One is there's a lot of us who've been doctors for a little while, so how do we get educated? And then, I'm also on faculty at Case Western Reserve University. I can just tell you, at the medical school, nursing school, dental school, how do we need to change the way we do graduate medical education so that the doctors that are coming up are getting this from the beginning? So I think there's both of those things. I guess the one other sort of fact I would point out, and I've been in practice now for about 20 years, we looked this up ahead of time.
Yeah, we did.
Medical knowledge is doubling now every 73 days.
Unbelievable.
So I could just tell, this is in terms of publications and other things. So I can't keep track of that. Even if I wasn't seeing patients, I couldn't keep track of all that, right? So I would say, for the benefit of our patients, to have these tools that can help synthesize all of this huge increase in information that patients should benefit from, and making this available sort of at the fingertips to patients, as well as physicians, I think is one of the huge opportunities of a certain type of generative AI. And I think there's always this question, again, you can think about in your own life, how well do you know the operating system of your computer, right? Different people, different of us know it to differing degrees. And so I think one of the big challenges, as a provider or as a patient even, what's the degree that we really need to understand how the AI works, and to what degree do we just think about, we're a user, it works for me, I understand some of the limitations. Another thing I'll just throw in there, and make you think about what's happening in your real life. I don't know how many of you have Teslas out there. Anybody Teslas? You don't have to admit. Okay, a couple people. But what about the self-driving car, right? How much do you really know that self-driving feature? Do you know all of the ins and outs of how it works, or do you just say, hey, the Tesla people know what they're doing. I press the button, it's worked fine for me. And again, people are going to have different comfort levels with that, right? So just think about some of those things. But I think this is a huge thing that I'm thinking a lot about as a Chief Health Informatics Officer of the MetroHealth system. How do I train my existing users, and thinking about patients too? And then a lot of this is happening in medical education as well.
It really lends an interesting flavor to your business continuity planning when you're thinking about this. So, at Cleveland Clinic, we do think about roles and your role in the ecosystem as we're thinking about access to tools. That's kind of one of the things that we use when we think about governance. So when we were talking about scribes, we first wanted to roll out scribes to experienced providers and not to residents and fellows. The thinking was that they needed to continue their education, write the SOAP note, get that muscle memory really built and ingrained. And as we moved on with our implementation, we kind of softened on that and thought, you know what, this tool is valuable enough, and we feel like the medical training to this point has carried people through, that we can start to roll this out to some folks who are earlier on in their medical career. But then it does bring up the question, maybe less about the scribe, because I think, in the event of an outage, everybody would be able to produce a note. But like a sepsis prediction tool, or a chart summarization tool. We don't have one of these live currently, but we have piloted them. And I found myself thinking about, how much are we going to be relying on these tools that we're not necessarily aware of? I think being very self-aware about the true role that our AI tools are playing in our healthcare is going to be crucial, and then planning for them appropriately in the event of a downtime.
In a moment that I want to add about the training, as you mentioned, I think it's really critical that all providers, if providers don't understand how AI works, they're less apt to trust or use it as well, right? So it's going to be really critical that we can set up, across-the-board training for all staff on how to understand how AI works, and and how to use it in the patient's care. But also training at the same time on how to communicate that to the patients. So that's where, you know, you have to pull in the communication principles. Right now, health professions across the United States get very little training in communication. So I've spent the last about 15 years training health professionals on how to communicate, and get a little pushback sometimes. Well, I communicate just fine, thank you. But after, you know, going through it and talking about actual patient experiences, then we get that aha moment. Well, maybe no, I am not being very clear. So training on the use of AI, but then also on how to explain that to the patients and their families. Critically important.
And with regard to explaining it, there's something in the governance framework called model cards. And these cards are really for the clinicians to understand what is this model doing, how accurate is it, what is its purpose in life, how did the data come to be? And so that is very helpful, so that the clinician feels the trust, and that trust is then moved into the patient-doctor relationship.
I want to squeeze a text question in. Which areas of healthcare are ahead of the curve with AI adoption?
I'm going to
radiology. I was going to radiology and
I'm
scribing.
biased in this
radiology,
area, but
right?
yeah, certainly radiology has been
Yeah.
advanced. I mean, we were forcing them to start doing voice recognition while they were looking at their images, and that was really one of the opening. And then all of a sudden, there was technology that said, did you look here, check this area out on the image. So they've been very technical over the years, but that's my personal thoughts on.
That's my gut. And then I would also put a plug in for my friends in pathology. They're doing amazing things in digital pathology as well.
I was actually going to just try to choose something different than clinical, and I'm going to say HR. And I'm going to say that the resumes that are coming into organizations now, there's the capability of pulling core elements associated with your backgrounds, your skill set, what you've actually worked on, your education, in order to determine, you know, instead of having 400 resumes, I get it down to 4, right?
Yeah, hi. My name is Soma. I'm a technologist. I live in the Bay Area, and I've built personalization platforms for Yahoo, Uber, Google, and most recently Airbnb. I'm here with my sister Shilpi. We're actually starting a health tech startup, so this is a great place to be. So firstly, thank you everybody for your time. And yeah, I drive a Tesla, so you know, that's pretty obvious. So my question is this, you know, the platforms we build in these tech companies, it's all about saying, how do we get users to engage more? Because the more you engage, the more likely you become a retained customer, convert, give revenues, all that story. But when I see health tech, do we really want patients to be more engaged and show up more and meet more doctors, spend more time, because there's a cost associated there? So my question is about engagement. How do you look at A, patient engagement, and B, how do you see AI playing a role there? And is that good or is that not good? Because, you know, there seems to be a engagement and a cost relationship, which is different in the tech world versus in this world.
Well, I think that.
Thank you.
Yeah, thank you for your question. So we talk about patient engagement. If we want people to engage more, they have to understand first. You know, so I think it's about raising awareness of what these tools can do, and they have to be trained on the use of how they work. So I'm thinking of things like chatbots, right? So patients may engage with that once that technology is ready to roll, right? So that doesn't cause more time with the physician, but I think that as long as they're trained up front, that's how you're going to get them engaged, because they don't understand it, they're less likely to trust or use it.
I would just add briefly, I think there's studies that show that what I do as a doctor only impacts someone's health maybe 15, 20%. So I'm hoping that AI allows all of us to engage more with our health, not necessarily with our healthcare provider, but with our health, because, you know, one of the challenges, again, you can think of your own selves, but most people engage with the healthcare system much less than 1% of their life. I mean, if you just look at the time, right, time they spend. Versus I would say that health is something we should be engaging with almost on a regular basis if we want to live the most healthy, productive lives we can, and hopefully AI can be a big conduit for that.
Yep. And of course, there's a cost of not engaging as well that we need to consider. I see that it's getting close to closing time here. I have some closing comments, if I could. So thank you all for being part of this conversation. We do hope it continues as AI becomes really part of us. We've heard from the panel that it is not just a wave of technology. This is not some new thing on the block. This is an epic inflection point in our technological progress as humans. It's big. And it has introduced a shift in how we think and practice healthcare. So we need to be responsible, more responsible than ever before. And we also need to think about the people, the patient-centered aspect of this. The tools are evolving fast. We've heard how much they're moving. Our values have to move fast with it. The way we govern this technology has to move fast. And our collective commitment to ensure that we're implementing this correctly needs to be sustained. The future of healthcare and AI is really sustained by trust and transparency. And it reminded us today about what it means to be human in a high-tech world. And we believe Northeast Ohio and Northern Ohio in general is positioned to lead in this effort. We think we can build a future of AI in healthcare that still feels deeply human at the core. So I thank the panel. I thank City Club for moving free speech forward in our community. You do so well. And thank you all for leading with innovation and integrity.
Thank you very much to Dr. Kelber, Karen Commander, Brian Lane, Jennifer Owens, and our moderator, John Paganini. Forums like this one are made possible thanks to generous support from individuals like you. You can learn more about how to become a guardian of free speech at cityclub.org. Today's forum was made possible thanks to the support of WellLink. It is also part of the City Club's Health Innovation Series presented by Medical Mutual. Our gratitude to each of these organizations for their continued support. The City Club would also like to thank guests at the tables hosted by the Academy of Medicine of Cleveland and Northern Ohio, Cuyahoga Community College, the MetroHealth System, and WellLink. Coming up at the City Club on Friday, July 18th, we will host Mac McCarthy with the Lincoln Institute of Land Policy for a forum on the need to invest in leadership and build communities that are defined by trust and civic engagement. Christine McIntosh, Planning Manager of the City of Euclid, and Gillian Prater-Lee with LISC Cleveland will join that conversation. That brings us to the end of today's forum. Thank you again to our speakers and members and friends of the City Club. I'm Michelle Nida, and this forum is now adjourned.
For information on upcoming speakers or for podcasts of the City Club, go to cityclub.org.
The ideas expressed in City Club forums are those of the speakers and not of the City Club of Cleveland, IdeaStream Public Media, or their sponsors. Production and distribution of City Club forums on IdeaStream Public Media are made possible by PNC and the United Black Fund of Greater Cleveland, Incorporated.